Hello and warm welcome to the World Anesthesia Day celebrations in Mumbai. I thank the organizers for giving me the talk on casing hepatic resection. When we're doing a case for hepatic resection, we must know about the indications and the extent of surgery that's been planned, whether it's an open or laparoscopic surgeries, associated comorbid conditions that the patient may be having. Anesthesia challenges must be anticipated and accordingly your plan should be ready. Monitoring that we will be doing for the patients, point of test availability and intention of monitoring, post-operative complications, role of ERAS in hepatic resection, and artificial intelligence and prediction of hypotension. The indications of liver resection usually are metastasis, HCC, neuroendocrine tumors, cadaveric organ retrieval, and liver transplant. Anesthesia for liver resection could start from a pre-anesthesia checkup. So give ASA physical status after the evaluation. See the perioperative risk, anticipate the perioperative risk, what is there of the patient. Be aware of the extent of surgery that has been planned. Usual plan is a general anesthesia plus epidural anesthesia. Try to optimize the medical conditions that may be there with the patient. Deep breathing exercise would help in a long way. Consent for blood transfusion as there would be anticipated blood loss, post-operative ventilator support, and hepatic failure should be taken. Pre-auto jet list should be there, and emergency resuscitation card must be ready as in any supramajor surgeries. Now, must remember that this is hepatic resection is a complex surgery with anticipated and massive intraoperative bleeding, associated hypotension, and massive fluid shifts may be there. Patient may have pre-existing liver disease, presence of cirrhosis, or may have received anti-cancer chemotherapy. There is a need for keeping the CVP low to reduce the blood loss. And there would be very levels of fluctuating hemodynamic parameters would make it very challenging and stressful to the anesthesiologist. However, in all this, you have to ensure that the urine output is maintained. Other complications that could be occurring during hepatic resection are air embolism, pneumothorax, and intraoperative fluids and postoperative organ dysfunction may be there. Coagulopathy. One must have to be careful for the safety or removal of epidural catheter in view of coagulopathy that may occur and other postoperative complications. These are the main anesthesia challenges. Intraoperative usually the patient is wheeled in, you pre-medicate the patient, usually take a large bore peripheral venous access, pass an epidural catheter, give general anesthesia standard endotracheal tube with positive pressure ventilation, central line, arterial line. Usually if patients are stable and optimized, they are done inserted after the general anesthesia. Warmer is used, fluid warmers as well as body warmers, and intermittent pneumatic compression pump device and rapid infusers are kept ready. So pictorially, if I want to show the monitoring intraoperative, then I would take an arterial line, internal jugular line, monitoring would probably be ECG saturation standard, arterial line which would give you the invasive blood pressure and pulse pressure variation, ETCO2 temperature, agent gas monitoring, CVP monitoring, and if you have advanced monitor like cardiac output and stroke volume variation, it would be desirable. Monitoring the temperature, central line is inserted to give fluids as well as CVP monitoring, arterial line to get the blood pressure, stroke volume variation, pulse variation, and cardiac output. Catheterization to monitor urine output. Point of care tests are usually possible and it is done using cartridges with hemoglobin, electrolytes, sugar, ABG, lactate. So you get the values within few minutes in the operation table itself without relying on the labs and transport delays that may be there. TEG, if available, would help if massive coagulopathy is occurring. Body warmer, pneumatic compression, rapid infuser, and fluid warmers are used for hepatic resection. These are under monitors and epidural urine. So you monitor the blood sugar, you do hemoglobin, point of care other tests using cartridges. So basically, you have a setup where you have all these three kept closed by the anesthesia machine. Another principles would involve would be giving less fluid still resection. Input output balance has to be maintained. There could be transient fluctuations of blood pressure during handling of the tumor or IVC or the liver resection itself. One must look for signs of air embolism and pneumothorax that may occur when there is resection occurring in the diaphragm end, very close to the diaphragm. Then this is occurring. If it is missed or it does not inform you and there is hypotension, it may be attributed to the bleeding that may be there, whereas the actual cause could be pneumothorax. Usually at the end of surgery, if your input output has been balanced and other massive events have occurred, patients usually get extubated. If needed, you may give ventilator support. Depending on other things that would contribute to these decisions would be blood loss, whether there is pneumothorax, hypothermia, and other comorbid conditions of the patient. Post-operative proper position, oxygen, analgesia, physiotherapy, they play a major role. So from OR, patient goes to the ICU. Other complications which may occur immediately, little delayed, would be coagulopathy, pulmonary complications, delayed would be biliary leak, post-hepatic liver failure, renal failure. Now, enhanced recovery after surgery, that's ERAS, is now there in lot of surgeries. So ERAS protocols are there including hepatic resection. So there are several papers that are the things that conclusion which come from those papers is that if ERAS protocols are followed, then you have lower morbidity, shorter post-operative stay, reduced cost, with no much difference in mortality and readmission stay rates. You have lower complications, length of stay. Other papers say early recovery of GI function in both laparoscopy and open liver resections. So what are the basic principles of ERAS in hepatic resection? The star indicates highly recommended. Preoperative counseling of the patients, minimal fasting, carbohydrate loading 2 hours pre-op, no bowel preparation, avoidance of long-acting anxiolytics, venous thromboembolism prophylaxis, perioperative nutrition. These are the key things in the preoperative phase. Intraoperatively, antimicrobial prophylaxis, a single dose and skin preparation with 2% chlorhexidine, highly recommended. Perioperative steroids, maintaining normotherapy is again high, so that our role comes in the important perioperative glycemic control, abdominal wound catheter or intrathecal opioids instead of epidural analgesia. So because that would probably get hampered because of the timing of removal of epidural catheter in view of coagulopathy. However, there are a lot of papers which say that epidural would not have much of a problem. Prevention of post-operative nausea, vomiting, maintaining low CVP during liver resection and use of balanced crystalloids is one very important recommendation for intraoperative in ERAS protocol. Post-operatively, early oral intake, early mobilization, and multimodal analgesia are the things to be done as per ERAS protocol. At discharge, usually there is normal or decreasing serum bilirubin, good pain control with oral analgesia, oral analgesics, tolerance of solid fluids. These are the criteria which decide and help you to discharge the patient. No IV fluid, patient does not need IV fluids. Patient is mobile independently or is at the preoperative level. Willingness to go home, normal body temperature, and no infection at the site of infection. Surgery-related ERAS protocols say that you should avoid Mercedes-Benz incision, minimally invasive surgeries when appropriate, avoidance of nasogastric tube, prevention of delayed gastric emptying by omental flap or for left-sided resection. Prophylactic nasogastric tube and prophylactic abdominal drain is supposed to be omitted as per ERAS protocol. Use of post-operative oral laxatives and minimally invasive surgery results in quicker bowel recovery and shorter stay in the hospital. Goal-directed fluid therapy with maintenance of low intraoperative CVP induces faster recovery. Early oral intake and mobilization are recommended. There is no evidence to prefer epidural to other types of analgesia. Now, a little bit about artificial intelligence and machine learning in prediction of hypotension. So as an anesthesiologist, we would obviously like to predict intraoperative hypertension, most desirable. The ability to prevent, which will help us in the ability to prevent hypertension associated complications. If we know that hypertension is occurring, we can predict it. There are machine learning algorithms are there, and this is an FDA approved now. It has what they have done is taken 3,000 odd individual features per cardiac cycle, and it has predicted whether arterial hypertension would occur. It has identifies an intraoperative hypotensive event 15 minutes prior to occurrence. Sensitivity of 88% with specificity of 87%. This has now been probably it has been approved by FDA. So human hypertension prediction index software. It predicts. It is a predictive decision support software. It detects the likelihood towards a hypertensive event before the event occurs. It provides insights to understand the root cause and inform a potential course of action. The human IQ sensor unlocks the human hypertension prediction index software. It connects to any existing radial arterial line. Three key elements of the prediction index software are hypertension prediction index as HPI parameter, value which ranges from 0 to 100, HPI high alert pop-up, HPI secondary screening. Now, what is the HPI parameter? It's updated every 20 seconds and provides continuous predictive insights into developing hypotensive events. Higher values indicate higher likelihood of a hypotensive event. The range is 0 to 100. So the second thing which I said was HPI high alert pop-up. It alerts when the patient is trending towards or experiencing an hypotensive event. HPI parameter values, I said it's 0 to 100. So more than 85 or 2 consecutive 20-second updates or reaches 100 at any time, it gives an alert. After that, there is an HPI secondary screen which is there. It's an advanced hemodynamic pressure and flow parameters are there in it, which allows to investigate and identify the root cause of potentially developing hypotensive events. It displays mean arterial pressure, cardiac output, SVR, PR, SV, SVV or PPV, as well as 2 additional indicators of contractility and afterload to provide a complete hemodynamic profile. So it's arranged in visually as per period, contractility and afterload. So whichever is the issue, you try to solve it accordingly. So the left first one is the parameter value. So 86, so it's a high alert. So high alert pop-up screen is come up, and on clicking that you have the secondary screen. So secondary screen gives you a lot of other information, SVR, cardiac output, stroke volume variation, etc. So this helps you in deciding what part needs to be tackled. So preload, if it's there that there's stroke volume variation or pulse pressure variation value will help us in deciding that. Systolic slope, maximum slope of the arterial pressure waveform from a peripheral artery will help in deciding the contractility. And dynamic arterial resistance ratio of PPV to SVV will further help in deciding the afterload. Sorry for this screen instead of face down. So you need to, of course, documentation of your case. So these are the consents and checklists, etc. To summarize, you should anticipate what is going to be happening to the patient, what extent of surgery, anticipate the key timings when blood loss will be there, be aware when the surgeons are dissecting, and maybe sometimes they clamp partially the portal vein and IVC. So accordingly, your fluid management should be there. You should be aware and very vigilant during these surgeries. Monitoring is key, and prompt management of all the problems and complications which may occur. Thank you very much for patient hearing. Wish you all again a happy World Anesthesia Day. Thank you.